Hi everyone, today we are going to be discussing a very exciting development in the investigation of women who have abnormal bleeding, which I understand has the potential to reduce the need for more invasive investigations like hysteroscopies in order to help in the diagnosis of precancer or cancer of the lining of the womb. Joining me today is Professor Martin Widschwendter, who is himself a gynecological oncologist and the inventor of this test. Martin, welcome. Thank you so much for joining me today.
Great pleasure. Many thanks for having me invited.
So, Martin, let's start from the very basics. Can you tell us what the name of this test is?
So the name of the test is called WID-QEC, and we also call it the WID-easy test. And WID stands for Women's Cancer Risk Identification, and the QEC stands for Quantitative Polymerase Chain Reaction Test for Endometrial Cancer. So quite a big name, but the simple
Mouthful.
form is WID-easy.
Okay, yeah, that's a good name. And tell me, what problem does this test do?
The test can solve several problems. The first is the late detection of endometrial cancer. Endometrial cancer is often detected late, particularly in women with obvious symptoms. Early symptoms like abnormal vaginal bleeding may be missed or dismissed, especially in postmenopausal women. The WID-easy test can detect cancer from cervicovaginal samples, allowing for early detection of endometrial cancer. The second aspect is the need for invasive diagnostic procedures in women who present with abnormal uterine bleeding or postmenopausal bleeding. All these women currently have to go to a transvaginal scan, and depending on the endometrial thickness, that means how thick the womb lining is, women will be then triaged to have a hysteroscopy and an endometrial biopsy. Currently, about 52 to 55% of all women who present with abnormal uterine bleeding and postmenopausal bleeding have to undergo this invasive diagnostic procedure. Our test identifies women who have very likely got endometrial cancer utilizing a very simple objective test, and only subject those women who have the highest risk to this hysteroscopy and endometrial biopsy. The third aspect that the test could potentially in the future address is a screening option for asymptomatic women. Currently, we don't have sufficient evidence to implement this, but possibly in the future, this WID-easy test could be implemented as a screening test, just like we know for cervical cancer screening. And that would then be a routine assessment detecting endometrial cancer early. One other aspect is the current diagnostic uncertainty with imaging. There is data coming from the States, from the National Cancer Institute, which just have been released last week, which shows that the currently ultrasound-based assessment of women with abnormal uterine bleeding misses up to 26% of endometrial cancers. This is quite a huge number. Our test detects more than 90% of all endometrial cancers without calling someone who has not got a cancer as a positive test. And the fifth problem, which we only became aware more recently, is the fact that there is a difference between black and white women in terms of performance of the ultrasound. The ultrasound is performing reasonably well in white women, but is not performing at all in black women. And our test does not assess the endometrial thickness, but it actually detects DNA, so that this is tumor material that is specifically altered. We call this epigenetic alteration. And this material is drained from the womb cavity into the vagina, and we are picking up this material and will then assess this using a very simple, high throughput objective test, which we have shown is working both in black as well as in white women.
Okay, wow. Okay, that's amazing. Wow, that's a really complete answer. So there are many, many positives to this test. And just for those who aren't aware about what standard practice is now, it involves, as you said, a transvaginal ultrasound scan, usually, which means the ultrasound scan probe goes into the vagina and measures the area of interest, which is the thickness of the lining of the womb. And depending on the results of that, we then perform a hysteroscopy, which is a camera test into the womb. And this is significant because many women, I would say, would avoid a hysteroscopy if possible, because it is at least quite an uncomfortable procedure. And at most, it can be quite painful for many women. So I think there's much interest in this test. I mean, that alone is really, really encouraging. When you add the possibility of screening asymptomatic women, it's really, really mind blowing. And that was not what I expected to hear. So really, really positive. So tell us, I've just explained what kind of the standard investigation for abnormal bleeding or postmenopausal bleeding is. Can you tell us how exactly the sample is obtained?
So it is very, very simple. You basically can obtain the sample exactly in the same way as it is obtained for cervical screening. So you insert a speculum in the vagina, visualize the
Yeah.
cervix, and you don't even need to scrape off cells from the cervix directly, but you just obtain some fluid which has accumulated. So bloody fluid or blood-stained fluid or clear fluid, whatever fluid is there at the top of the vagina, close to the cervix. And that fluid is being transferred into a vial, and we are extracting then the DNA out of this vial and do the test. This is a simple PCR test, like a COVID test, and then that gives you an objective result.
And is it, just to be clear, is it like a swab that you get the fluid on, or is it like a pipette that you suck some of the fluid up?
It is purely
What
a
exactly?
swab that
It's a
absorbs
swab.
the
Okay,
fluid in the vagina, and that's it.
got it.
So
Okay,
completely
so pretty
painless.
straightforward
We
and
have
pretty painless. Yeah, yeah.
Exactly. So completely painless. We have, in fact, also got evidence that the sample could be taken by the patient herself. We are not
Mm-hmm.
recommending this right now because the sensitivity of the test is slightly lower. So we currently only
Okay.
recommend the test to be taken by the gynecologist or by a midwife, exactly the same way as it is for cervical cancer screening. Simple and easy.
Okay. And then once you obtain this swab, what happens to it then? Is it sent away to be analyzed, I imagine? And how long does it take to get the result?
Exactly. The sample is taken, it's transferred into a vial. The vial is shipped to the lab, and it takes the lab between 2 to 4 days to analyze the sample and then get the result back to you. The
Okay.
time, I shall say, the time to process the sample in the lab will substantially shorten the more samples the lab will obtain. Because we've
Yeah.
basically set up the test as a so-called high throughput assessment, where the 3 steps, DNA isolation, modification, and PCR, is all done by a robot. But obviously, the more samples you have, the faster these can be processed.
Okay. And you've mentioned it's really accurate. So how accurate is it? So if we compare your test with, for example, an ultrasound scan plus a hysteroscopy plus an endometrial biopsy, can you tell me how they compare against each other in terms of diagnosing endometrial cancer or endometrial abnormalities, hyperplasia, overgrowth of the lining of the womb?
So we've done a big study at UCLH where we involved 400 women who came within half a year to the diagnostic unit at the University College London Hospital. And
Mm-hmm.
we compared the test to the current gold standard. And imagine there's 100 women who come with postmenopausal bleeding. only 3 of these women will have endometrial cancer. 97% or 97 women will not have a cancer. So the minority will have a cancer. The current ultrasound-based strategy, if you take an endometrial thickness of 3 millimeter, will identify 56 out of the 100 women to be at high risk and requiring a hysteroscopy and a biopsy. One cancer will be missed, so this will be 0.3 of the entire 100 samples, 100 women will be missed. If you do our test, the WID-easy test, out of the 100 women, only in 6 the test will be positive, and amongst the 6, 3 have a cancer. So these are roughly the figures. So you have about 52 false positive in the ultrasound, whereas you have only 3 false positives in the test, and you detect exactly the same number of women with the cancer.
Okay. And you said that there's a small risk of missing cancer with ultrasound and hysteroscopy. Is it the same with the WID test?
So we have, our test has a sensitivity between 91% and 100%. We've done 9 different studies. Depending on the different setting of the study, we're detecting between 91 and 100% of all cancers. Literally, in white women, the same figures apply for the ultrasound. In black women, the ultrasound performs much worse. So you miss much more cancers by ultrasound. You miss in particular, and this is evidence that had just accumulated, about 23% of the poor prognostic serous cancers. So there's a subtype of cancers which have a worse prognosis than the majority of other cancers, and they are called serous cancers. And you miss about 23% of those serous cancers with the ultrasound, whereas the WID-easy test has no discrimination between endometrioid, which is the classical endometrial cancer, or the serous cancer. So it also detects the serous cancer equally well.
Okay, perfect. So women will be interested in how this will affect their patient journey, and I'm sure they'd like to know exactly what will happen at every point. So can you walk me through a patient journey of a patient who has, for example, postmenopausal bleeding and maybe has been given the option of the WID test, WID-easy, and she's going to have the WID-easy test? Can you explain exactly what happens all along her pathway?
So currently, a patient experiences abnormal bleeding above the age of 45. So this is how the test has been validated, or experiences bleeding which happens after the menopause. And any bleeding which happens after the menopause has to be assessed. So the patient goes to her GP, and the GP currently would refer the patient to a gynecological diagnostic center, whatever her referral center would be. And then an ultrasound will be done, and depending on the ultrasound outcome, meaning if the endometrium is thicker than 4 millimeter, the patient would be advised to undergo hysteroscopy and a biopsy. If a cancer is being found, then immediate treatment. With the WID-easy test, the patient would again come to her GP. The GP would still refer the patient to a diagnostic center at the moment. And then in the diagnostic center, the patient would be offered the WID-easy test. If the WID-easy test is positive, the patient would instantly be referred to a hysteroscopy and an endometrial biopsy. I would recommend to do this under general anesthesia because it's much more convenient and easier to perform. If the WID-easy test is negative and the patient has no massive symptoms, the patient could be seen 3 months later after conservative treatment or after a observation. And if the symptoms persist And if the patient still has an endometrial thickness which is concerning, the hysteroscopy and biopsy can be done at that stage without any urgency. What we would aim for is that the patient, if she experiences bleeding, could see her GP, and the GP, respectively a midwife at the GP, could take the sample straight away and only refers patients who are WID-easy positive to a diagnostic center. That is for the future. So currently we would still recommend to have the patient assessed in a diagnostic unit.
Okay. And so therefore it doesn't completely eliminate the need for hysteroscopy, but it'll reduce substantially the number of women who need to undergo this procedure. Is that right?
This is absolutely correct. So the test assesses DNA, and the DNA, if it's abnormal, would indicate the presence of endometrial cancer. But before you treat the patient, and that applies to any oncological diseases, to any cancers, before the treatment, you need to verify the cancer by a histological assessment. Yeah. So you need to see the cancer under the microscope, and only then you would initiate the treatment. And that applies for any cancer: breast cancer, ovarian cancer, prostate cancer, any cancer.
And also, hysteroscopy isn't only used to diagnose cancer. So sometimes a woman can have, for example, an endometrial polyp, like a skin tag of the lining of the womb, and that can cause irregular bleeding. But maybe, would you agree that it sounds like this test will be able to clarify for us the urgency with which one woman over another may need a hysteroscopy? If we've essentially ruled out cancer, she may still need a hysteroscopy, but it means we can concentrate more quickly on the women who are at high risk for cancer. Does that make sense?
This is absolutely correct. So the current problem is that there's so many women deemed to require hysteroscopy and endometrial biopsy, so that there's a backlog. So you can't really prioritize women who have a very high chance for cancer to have the hysteroscopy and endometrial biopsy done immediately. And that causes a delay in diagnosis. And we know data from the beginning of the pandemic done by our colleagues in England, who have assessed in a modeling exercise what additional death, so what additional women dying from the endometrial cancer would be triggered by a delay in diagnosis. And what they have calculated, that if you delay the diagnosis by, let's say, 6 months, you have 48% more women dying from endometrial cancer compared to an immediate diagnosis and treatment. So almost half more women die from cancer if you delay the diagnosis and respectively the treatment for 6 months. And that, I think, in itself requires a change in taking care, or in the care of, or in the pathway, so that women who really have a very high chance of cancer will be prioritized. Okay. And this is what this test allows.
Yeah. I mean, that is directly translating basically into saving lives, earlier diagnosis, less morbidity, less major surgery, etc. So another big plus point. So patients currently, if patient, for example, comes along with postmenopausal bleeding, and as you said, we use the endometrial thickness, the thickness of the lining of the womb, measurement of 4 millimeters in a woman who's not on HRT, in order to decide whether she needs a biopsy or hysteroscopy, because the thinner the womb lining, the less likely it is to be cancer or precancer. So a woman who comes, for example, who has an endometrial thickness of 3 millimeters, we can reassure. But however, if she has recurrent bleeding, if it happens again, then we say, well, although your womb lining is thin, we do think it's safer for you to have a hysteroscopy and biopsy. Is that the same? I think you mentioned this before, actually, you touched on it. If she has a normal WID-easy test and has recurrent bleeding, is that an indication to say, well, actually, let's have a closer look and let's do a hysteroscopy?
The WID-easy test identifies women who have a very high chance of endometrial cancer, but there's obviously also other causes that cause bleeding, some of which you can treat with progestins, some of which can be treated even with estrogens if there's an atrophia that causes the bleeding, some of which require antibiotics, and some of which require a hysteroscopy and resection of a polyp that causes bleeding. Even if it's not a cancer, these polyps, they can cause bleeding. And so if you remove this polyp and thereby stop the bleeding, that's a sort of almost a therapeutic intervention to stop the bleeding and make the patient more comfortable.
Okay. Well, this test sounds very exciting. Almost too good to be true, but I'm sure it is true. And it sounds that in the future, it may have even more applications to have a huge impact on women's healthcare. What I'm sure every listener is wondering is this available at the current time?
The test is available currently to all private gynecologists, and the UK team named Advanced Global Health is leading the implementation across the UK. Obviously, we are working to get the test applied in the NHS setting, and there's 3 real-world evaluations due to start imminently. That's one of the prerequisites for the NHS to adopt the test.
Okay. So, do you have any idea about timescales?
You mean about timescales to adopt the test in the NHS?
Yes.
Well, obviously we would be thrilled if the test could be available to all women within the next 1 or 2 years, but it's not up to us. We are working very, very hard with NHS and other stakeholders, and so far we've only got very positive feedback. But as always, implementing something which is completely new and almost revolutionizing always takes time, and quite understandably has to be taken with caution. And so this is what we are working on at the moment. But we are confident, that the test could really, and this is our goal, be available to all women, at least in the secondary care, and ideal then in the primary care setting, where a woman comes and then she will see her GP. The GP herself or the midwife takes a sample, and then the test says, yes, you need further assessment, or no, you don't. And then one aspect that we are working on is to see whether the test can also be applied to women who come with abnormal bleeding before the age of 45. Obviously, the chance that a younger woman, younger than 45, has an endometrial cancer is very low, but nevertheless, ultrasound in young women is not really feasible because the endometrium shrinks and grows as a function of the menstrual cycle. And from that perspective, the ultrasound has no real role in premenopausal women, and hence the test could be really useful. We also know, and this is something which is an additional plus of the test, that the test detects almost 100% of all invasive cervical cancers. So cervical cancer is also a cancer that arises from the womb, but not from the body of the womb like endometrial cancer, but from the neck of the womb, the cervix. And there is about 30% of women who don't attend cervical cancer screening, and they would come to their GP in the first instance if they bleed, because the cancer also bleeds. And so the test would, in this case, also detect the cancer which arises from the neck of the womb, the cervix. So this is an additional aspect that we have assessed both in white as well as in black women.
Okay, brilliant. And tell me, Martin, what is your vision? What is your big vision for the future of this test and the impact it'll have on women's healthcare?
So we don't lack vision. The vision is to really have the wish is to say we give women the autonomy to assess whether their bleeding is caused by a cancer or not. In an ideal setting, and this is really for the future, for those women who, for whatever reason, don't want to see a gynecologist or a GP,
Yeah.
we would like to have this test available via a self-sample. So women could take the sample herself at home and send the sample via post to the lab. That is for the future. This is not yet established. We will need to do a lot of additional work to make this happen. We would like this test to be broadly implemented. This is really key. This is why we have developed it for every woman, irrespective of whether she can afford it or not. And we would like to have it worldwide implemented. We do have additional visions, which is, can we also transform cervical cancer screening? We've just published a big paper last year where we would like to see cytology, which is applied in women who are HPV positive, so cervical screening HPV positive, not requiring a cytology, because cytology is still a subjective way, so you need to look with your eyes under a microscope and see whether these cells look abnormal or don't look abnormal. We have developed a similar test which could replace cytology. Again, this is not yet in clinical implementation. The third thing that we would like to develop is a test that would identify women who have a risk for ovarian cancer. So this is very much academic work, which we hope to be able to implement in the next few years. Still no impact right now, but hopefully something that we can do. It is based on the same principle, assessing a swab, but predicting the future risk for ovarian cancer. And the fourth big vision is to use the same test principle, cervical smear sample, to predict the risk for poor prognostic breast cancer, in particular for women below the age of 40. So these are the sort of projects that we are working on, so that we can use one sample from cervicovaginal space that allows us to detect or at least predict the future risk for all 4 women's cancer, which are about 50% of all cancers that women are developing.
Okay, you certainly do not lack vision. I agree. Amazing, amazing work. For those who are interested, Martin has kindly forwarded a video which gives us more information about how the test works, and that'll be at the end of this video. So I hope you enjoy that. Martin, it only remains for me to say thank you so much for giving of your time today, as you are clearly a very, very busy man. And I would like to thank you on behalf of all women for your work in producing this test, which sounds, it's no exaggeration to say that it sounds absolutely revolutionary. Thanks for all of the hard work that was involved. And please do keep working, because the future sounds really, really bright for women. Thank you so much.
Many thanks, Gail, for giving us the opportunity to present our work. Many thanks.